we're going to approach a disorder that, at least for me, is very challenging, making sure the kids stay healthy. And we need as many new ideas as we can get in managing it. So expanding the spectrum of Gorham Stout, we're going to have two speakers. First, Dr. Dellinger is going to bring us up to date on the basic science. And then Dr. Kelly is going to bring us more clinical. Have I got the right order, Mike's? And so let me now turn this over to them. Thank you so much for being with us.
So thank you, Dr. Tosi. This is Mike Kelly. I will present first, and then Dr. Dellinger will present after me. Let me just see. And can you see my screen?
Absolutely.
Yes, we can.
Okay. All right. Oops, sorry. So basically today I've had the great pleasure of speaking with Dr. Dellinger, and we're going to talk about the interplay of lymphatics and bone. And I'm going to speak about the clinical insights in the clinical care of patients, particularly with Gorham Stout. And Dr. Dellinger will actually speak to the exciting new preclinical findings that we're seeing that are rapidly coming into or impacting our clinical care. So the learning objectives for today are to understand presentation and genetics of Gorham Stout disease, available treatment options or current treatment options for Gorham Stout disease, and then have a cursory understanding of the mechanisms of bone loss, particularly cortical bone loss in Gorham Stout. And again, I think most exciting is really appreciate how preclinical models are continuing to inform the diagnosis and treatment of patients with Gorham Stout disease. So to talk about Gorham Stout disease, we need to talk about lymphatic development. So sorry, guys, I'm having trouble here. Okay, so basically, the lymphatics is a vascular system, much like the arterial and venous systems. You see blind capillaries, endothelial blind capillaries that flow into larger vessels, collecting vessels that ultimately deliver fluid back to the circulation. From a developmental perspective, these lymphatic endothelial precursors actually arise from the cardinal vein, one side of the cardinal vein, and are actually enticed to migrate and differentiate through an interaction of vascular endothelial growth factor C and the VEGF3 receptor on lymphatic endothelial cells. And this leads to a maturation that includes not only vessels, but lymph nodes and collecting vessels within the trunk. Okay. So from a cartoon perspective, or this presents a cartoon of the differing anatomies within the lymphatic system. So again, at the capillary end, the anatomy is such that facilitates the exchange of fluid as well as macromolecules and cells. As you move more centrally, you develop basement membranes, the wrapping of smooth muscle cells, as well as the development of valves. And this really effectuates or affects the propulsion and unidirectional flow of the fluid. And then ultimately, these enter large collecting vessels in the trunk and end in the thoracic duct, which actually then terminates into the subclavian. So lymphatic anomalies are abnormalities of lymphatic growth or lymphatic development. And they occur as a result of disorders, or they're considered disorders of somatic mosaicism. So activating mutations in genes, in particular growth signaling pathways, have been shown to cause various lymphatic anomalies. You can see, again, a cartoon depicting sort of normal lymphatics up here, normal lymphatic structure, and then lymphatic malformation that has very abnormal anatomy of veins, as well as function of, of the lymphatic vessels, and abnormal lymphatic vessel function as well. These can occur as simple cysts, as demonstrated here in this picture, in a child that presented with a large macrocystic lymphatic lesion in his neck. And they can also be more complex and associated with syndromes, including PIK3CA related overgrowth syndromes like CLOVES and KTS, which is demonstrated in this picture here, as well as RASopathies, including Noonan syndrome. The classification for vascular anomalies has been performed by the International Society for the Study of Vascular Anomalies, or ISFA. They recently released a new classification in 2025. And vascular anomalies are broadly broken down into vascular tumors, as well as vascular malformations. And vascular malformations are generally broken down into fast flow malformations that include arterial components, as well as slow flow malformations that include capillary, lymphatic, venous, and multiple combined malformations. And within the lymphatic malformation perspective, we have isolated malformations that include macrocysts, and macrocysts meaning balloon-like structures, fluid-filled structures. Microcysts, I like to think of more like a honeycomb type of picture, where you have a fair amount of tissue with small fluid cysts that intersperse that tissue. And then most are mixed, either macrocytic or microcytic. Include both macrocytic and microcytic components. Again, as the names suggest, these are isolated. They tend to occur in a particular area and not be diffuse. Complex lymphatic anomalies, as the name suggests, are more complex. These include general lymphatic anomaly, Gorham Stout disease, caposiform lymphangiomatosis, central conducting lymphatic anomaly, and a new addition is generalized lymphatic dysplasia. The central conducting lymphatic anomaly can be either isolated, found on its own, or it's been associated with syndromes, particularly the RASopathies, in which about 20% of patients with Noonan's and Noonan's-like syndrome will have abnormalities of their central lymphatic collecting system. Generalized lymphatic dysplasia is really has characteristics of both complex lymphatic anomalies and primary lymphedema. So they often present, it's a newly diagnosed or newly discovered entity that presents often with significant lymphedema, but they can also have other characteristics of more complex lymphatic malformations. This is just a cartoon that depicts the different types of lymphatic malformations. Here you can see isolated malformations, either macrocystic or microcystic. The complex lymphatic anomalies often are multifocal. So they often will involve soft tissue in various parts of the body. They often involve viscera, and characteristically, they involve the bone. And the bone phenotype actually differs across the complex lymphatic anomalies, as we will see. So it's discussed, these lymphatic malformations and anomalies are due to somatic gene variants, meaning these genetic changes occur after fertilization during development. They're not inherited from patients or from parents. So as a result of that, depending upon the cell type that the mutation occurs and the timing during development which it occurs, you can see quite disparate phenotypes, ultimate phenotypes. So again, you can see isolated involvement in a particular area, or you can have multiple areas that can be involved depending upon those variables. And then the growth pathways that are involved are primarily the PIK3CA, mTOR, AKT pathway, as depicted here, and then the RAS/MAP kinase pathway depicted here. Within this cartoon, you can see different colors, and the colors represent the genes that are most commonly associated with either lymphedema in green, lymphatic malformations in blue, and complex lymphatic anomalies are seen in red. And most lymphatic malformations, not all, but most, actually are caused by PIK3CA or mutations in the PIK3CA gene. In general, the complex lymphatic anomalies tend to cluster in the RAS/MAP kinase pathway, but clearly there's overlap between those two pathways. I also like to point out that there's a lot of crosstalk that occurs between these pathways. So when you have gene mutations in the RAS/MAP kinase pathway that effectively alter activity of this pathway, you're not only affecting RAS/MAP kinase pathway, but also the PI3 kinase pathway to some varying degree. Complex lymphatic anomalies are really defined by the presence of high-risk features. We've talked about these a little bit. They often have diffuse lymphatic malformations. They involve soft tissue, bone, and viscera. They often have the presence of fluid collections in large cavities, particularly pleural fluid and/or ascites. Many, or at least some, will present with coagulopathy, and also those that present with central collecting lymphatic problems will also present with protein losing and enteropathy. And these, as we talked about, all have bone phenotypes, but they can be distinct with some overlapping features. This is just a summary slide of this clinical findings for CLAs. And what I'd like you to focus really here on is the bone disease burden. And with Gorham Stout disease, the bone disease burden is quite high, whereas GLA and KLA have low to medium bone burden, and CCLA has a low bone burden as well. So we are not aware of any bone disease in GLD, but that has not really been looked at in any great detail to this point. All right, so what we're going to do today is really talk and focus on Gorham Stout disease. And the reason is that it's a disease that primarily affects bone. What we see in this disease is progressive osteolysis with loss of cortical bone. And that really distinguishes GSD from the other forms of complex lymphatic anomalies. In GLA, KLA, and CCLA, you can see the loss of trabecular bone, but only with GSD do you see the loss of cortical bone. GSD often presents in a multifocal or regional bone involvement. So again, head and neck is often a primary location for the presence of GSD. You can have both soft tissue masses, and depending if the bone involvement is actually located in the thoracic vertebrae, or ribs, you can have massive pleural effusions associated with that. Obviously, there can be functional impairment related to the bones that are involved, and there is a mortality rate, particularly with patients that have pleural effusions. Mike will talk, Dr. Dellinger will talk a lot more about this, but the KRAS gene has been implicated in at least a couple of patients with GSD to this point. And these are pictorials basically showing literally the loss of bone. So here's a humerus where you have a loss of bone structure. This is a femur where you see sort of a moth-eaten ratty appearance with cortical disruption along the length of the femur. So again, this disease was initially called vanishing bone disease, and you can see from these pictorials why that was the case. These are additional findings. This is actually a young girl that presented with hip pain and swelling. She was found to have significant cortical disruption of both the proximal femur as well as the hip. This is just a T2 weighted MRI fat-sat sequence that shows hyperintensity or fluid within the soft tissues as well as the bony structures within the femur and hip. This is actually a 9-year-old boy that presented with headaches and was found to have a skull deficit on a clinical exam. And imaging, including CT, was done. And this is a composite CT that basically shows occipital and temporal defects within the outer skull here. So you can see, again, pretty obvious skull deformities in this child. And this is a 13-year-old girl that presented with pleural effusions. Imaging showed the potential loss of ribs, and this was confirmed on CT scanning. Again, this is a composite CT, which shows loss of ribs in a very regional fashion. Sorry, having trouble with words today. And then this is from a histologic perspective. This is the histology from a H&E. You can actually see large cystic structures within the bone. It's, again, here pretty clear. It's unclear what type of cysts these are. However, when you stain these, they often will stain with lymphatic endothelial specific immunostains. This one is podoplantin or D240. Live1 and Prox1 are also used to identify lymphatic endothelial cells in histology. So the clinical presentation of GSD really varies depending upon where the bone is involved. So most commonly, patients will present with pain and swelling, as well as pathologic fractures. But from from a anatomic specificity perspective, patients that present with head and neck disease often will present with CSF leaks, including rhinorrhea and otorrhea. They can present with headaches, recurrent headaches, nausea, vomiting. They can present with hearing problems as well. Patients that have mandibular involvement often present with loose teeth. They have a progressive facial deformity. And those that present in the thorax or in the vertebral column often present with pleural or pericardial effusions associated with this, and also can be associated with respiratory failure. And then there is cutaneous involvement that's been described in some patients with GSD as well. So treatment of a GSD has really evolved, probably not as much as we had hoped over the course of the last 2 decades. But again, I think that people focused on the likelihood that with cortical loss, that the osteoclasts were involved in this process. And so bisphosphonates actually were used early on as far as trying to mitigate and moderate GSD. And this is just an example. Unfortunately, the literature really is a description of case reports and very small case series with regard to GSD. So again, this is one where we have multiple patients that with GSD that was confirmed radiographically and histologically. And these patients were treated with various bisphosphonates at different doses as well as different intervals over the course of several years. And what we came away with is that the bisphosphonates by themselves actually were helpful in moderating disease in some patients, but not the majority. And again, not clear really the long-term effects of the use of bisphosphonates in particularly young children with developing skeletons. So you can see we have sort of the immediate effects of the bisphosphonates listed here in this report, but the long-term outcomes are not reported. So sirolimus actually was used to treat a number of patients with first with vascular tumors and then various vascular malformations. And this stemmed from the work that showed that mTOR was vitally important to lymphatic endothelial function. And so the initial patient that was treated with sirolimus was refractory to all of the standard treatments that were being used. And because of this finding that sirolimus or mTOR inhibitors could be effective in treating lymphatic endothelial cell disorders, this patient was treated. And the patient was actually had a remarkable response. The patient had a vascular tumor called caposiform hemangioendothelioma, or KHE. And this was done and reported by Denise Adams in Cincinnati in 2011. That actually started a phase 2 or initiated a phase 2 trial to look at sirolimus in a variety of different lymphatic diseases, and then subsequently a variety of vascular anomalies. And what was found is that sirolimus alone was actually a very effective treatment in many patients with lymphatic malformation, particularly isolated lymphatic malformation. This is actually a trial, or not a trial, but it's actually a report from Ricci that incorporated some of the patients that were treated on the phase 2 trial and then subsequently off study treatment with sirolimus alone. And what I would like to just show you in this is that, again, numbers are small. There are, about 4 or 5 patients that with GSD and GLA that were incorporated into this study, and most of them actually showed improvement, and again, clinical improvement overall. But only one of the 5 actually had progressive disease. Although the patient and the clinician agreed that they had clinical improvement, there was really no significant change in the bony disease or bony burden of these diseases. So So again, and this is it really manifests here with the clinical assessment at baseline and then the clinical assessment as a response. And most of these patients, either from a clinical perspective, had responsive or stable disease. So what this showed us was that sirolimus was actually, again, good in moderating disease symptoms in some patients, but it still did not result in significant changes in the underlying pathology of the disease. So again, like true oncologists, if one works, then two will work better. And that was the philosophy in this particular study, where they actually looked at sirolimus and bisphosphonates in a series of patients with GSD. And you can see the age group here is a little bit older than what you've seen in previous studies. And they involve lesions, bony lesions in different areas. What is clear, again, is that when sirolimus was used in combination with bisphosphonates, and I'll tell you that the bisphosphonate dose and interval was variable between these patients, that they actually did have a clinical response, but again, very few of them had moderation of underlying bony disease. So many of these patients were treated for a period of time. They actually improved. They were taken off treatment, and many of them recurred over the next several months to years. And then this is the most recent and probably most complete cohort that we have. Here we have 9 patients, but now it's up to about 12. And this is consecutive patients followed by Bertulli's group in Italy. And since 2017, they've actually been treating all of their patients with GSD, diagnosed with GSD, with sirolimus and bisphosphonates. Again, there is some variability in the type of bisphosphonate that's used, in the interval that's used, but again, more consistent than what we've seen in previous studies. What I can tell you from this group, from what's been published and what's been presented, is that all of these patients actually had a clinical response to sirolimus and bisphosphonates. But again, radiographic response occurred in very few patients, and the duration of response is still questionable. We really haven't seen a lot of the data yet on long-term responsiveness and long-term toxicities in these patients. And you can see here, in contrast to the previous study, many of these patients are actually were diagnosed very early in life. And so two things that have come out of that, or two conclusions from this, is that number one, as we've raised awareness of the entity of complex lymphatic anomalies in GSD, these entities and diseases are being diagnosed at an earlier and earlier age. So what we know about outcomes and potential limitations for GSD is that sirolimus and bisphosphonates are effective in moderating GSD in some patients. However, the long-term outcomes of the use of bisphosphonates in young children with growing skeletons are still being realized. And obviously, we need more effective and safer treatments that actually get to the underlying, or treating the underlying pathology in a mechanistic derived way. So thank you, and I will hand this off to Mike Dellinger.
Thank you, Mike. And while I pull up my screen, I'll just take this opportunity to thank the organizers for inviting me to speak at today's webinar. And during my part of the presentation, I will share how advances in preclinical research are shedding light on the underlying disease mechanisms of Gorham Stout disease. And I will also discuss how these advances are enabling a precision medicine approach for treating this life-threatening disease. So at the time we started our research on Gorham Stout disease, the molecular mechanisms driving the abnormal growth of lymphatic vessels in patients were unknown. However, a lot was known about the molecular mechanisms controlling the growth of lymphatic vessels during normal development. And over the past 25 years, the growth factor VEGF-C has emerged as the principal driver of lymphangiogenesis, the growth of lymphatic vessels. VEGF-C is a ligand for the receptor tyrosine kinases, VEGFR2 and VEGFR3. Both of these receptors are expressed by lymphatic endothelial cells and stimulate the formation of new lymphatic vessels. Animal studies as well as human studies revealed that loss of VEGF-C impairs the formation of lymphatic vessels, where conversely, overexpression of VEGF-C has been shown to stimulate the formation of lymphatic vessels and tissues. So based on those observations, we hypothesized the overexpression of VEGF-C in bone could stimulate the formation of lymphatic vessels in bone and cause mice to develop a phenotype that resembles Gorham Stout disease. So importantly, if our hypothesis were true, we would then be able to address fundamental questions regarding the development of lymphatics in bone and the mechanisms by which they promote bone destruction. So to test our hypothesis, we generated mice that overexpress VEGF-C in osteocytes, osteoblasts, and chondrocytes. And we have used the TET-off system to spatially and temporally control the expression of VEGF-C. In our system, the Ostrix promoter drives the expression of a tetracycline transactivator. And in the absence of doxycycline, this tetracycline transactivator induces the expression of VEGF-C. When doxycycline is present, it binds to the tetracycline transactivator and prevents the expression of VEGF-C. And we give doxycycline to our mice by putting it in their drinking water. So we had found that overexpression of VEGF-C by Ostrix positive cells during development caused an embryonic lethal phenotype. So to bypass that embryonic lethal phenotype, we inhibited the expression of VEGF-C by Ostrix positive cells during embryonic development and then induced its expression in mice during postnatal development. And when mice were 35 days old, we collected their bones for analysis. And what I'm showing here are sections of tibia from control and mutant animals. And these sections were stained with an antibody that recognizes LIVE1, which is a marker of lymphatic endothelium. And as anticipated, we did not observe lymphatic vessels in healthy bones from control animals, whereas the bones from our mutant animals were filled with lymphatic vessels. So these data suggest that overexpression of VEGF-C by Ostrix positive cells is sufficient to stimulate the development of lymphatic vessels in bone. We then assessed the effect of this expression on bone structure. What I'm showing here are micro-CT images of femurs and ribs from control and mutant animals. And we found that the porosity of the cortical bone was significantly greater in our mutant animals than the control animals. So these results suggest that overexpression of VEGF-C not only stimulates the formation of lymphatics in bone, but we also see this destruction of cortical bone, and these are two hallmarks of Gorham Stout disease. We then wanted to determine whether this loss of cortical bone was associated with any sort of dysfunction of the bone. So to do that, we performed a 3-point bending assay where we applied force to the bones until they broke. And we found that significantly less force was required to break the bones from our mutant animals than the control animals, demonstrating that these bones that are filled with lymphatic vessels are weak. We then set out to investigate the cellular mechanisms driving this loss of bone in our transgenic mice. And as Mike mentioned before, osteoclasts had previously been implicated in the pathogenesis of Gorham Stout disease. So that led us to evaluate osteoclasts in our mutant mice And to do that, we stained tissue sections for trap activity, which causes osteoclasts to appear pink or red. And in doing this, we found that bones from our mutant animals had significantly more osteoclasts than control mice. And to extend these observations, we collected blood from our animals and measured the circulating levels of this factor CTX1, which is a circulating biomarker of osteoclast activity. And we found that CTX1 levels were significantly greater in our mutant animals compared to the control, supporting our observations by trap staining. So what I've shown so far is that expression of VEGF-C in bone stimulates a phenotype that resembles Gorham Stout disease. We see lymphatic invasion of bone and the destruction of cortical bone. We then set out to determine whether we could reverse the disease phenotype in our mice by inhibiting the expression of VEGF-C in mice with established disease. And there was reason to believe that the lymphatic phenotype of our mice would not be reversible. And that is because people had previously reported that lymphatic vessels do not regress following the withdrawal of a growth-promoting stimulus. So this is very different from blood vessels. If you could provide blood vessels with VEGF-A, the blood vessels grow. If you take away the VEGF-A, the blood vessels will regress. Lymphatic vessels are different. An example of that is shown here, where VEGF-C was expressed in the airways of the mice. And we see that following the expression of VEGF-C, the lymphatic vessels form. And then following the withdrawal of VEGF-C for up to 19 months, these abnormal vessels persist. So we went into this experiment thinking that the lymphatic abnormality of our mice would actually persist following the withdrawal of VEGF-C. But to our surprise, we found the opposite. And I'm just going to walk through this experiment where in this experiment, we, like before, induce the expression of VEGF-C for 35 days. And then in a cohort of mice, we then either inhibited the expression of VEGF-C for 28 days or 56 days. And what I'm showing here are longitudinal sections of ribs that we've stained for another lymphatic marker called podoplanin. And in control animals, you could see lymphatic vessels restricted to this periosseous muscle. There are no lymphatic vessels in the cortical bone or marrow cavity. When we express VEGF-C in Ostrix positive cells, that causes lymphatic vessels to grow in bone, and it also stimulates the expansion of this periosseous lymphatic network. And to our surprise, when we inhibited the expression of VEGF-C, the lymphatic vessels in the bone, but not the periosseous lymphatic vessels, regressed. And we are still investigating this to further understand why lymphatic vessels in bone depend on this continued VEGF-C or pro-growth signal for their survival or maintenance in bone. So in addition to characterizing the lymphatic phenotype, we also imaged bones by X-raying our animals. And we found that when mice have active disease, their bones exhibit this moth-eaten appearance. And following the withdrawal of VEGF-C, the bones switch to having a more normal appearance. And we can not only see this by X-ray, but also by histology, where these are cross-sections of femurs. And you can see mutant animals with active disease have these pores within their cortical bone. And then following the withdrawal of VEGF-C, the lymphatics in the bone disappear and the bone regains its normal appearance. And in addition to that, we also see a decrease in osteoclasts in bone, as well as in circulating levels of CTX1. So to summarize this part of the presentation, we found that expression of VEGF-C in bone by Ostrix positive cells stimulates the development of lymphatics in bone. We've also seen that it stimulates osteoclast-mediated bone resorption, and that we can reverse these abnormal phenotypes by inhibiting the expression of VEGF-C. So during these experiments, we became very interested in the cellular origins of these abnormal lymphatic vessels in bone. So during the course of our studies, there was a popular hypothesis in the field that these abnormal lymphatic vessels in bone could potentially be originating from mesenchymal stem cells in bone that differentiate into lymphatic endothelium, or perhaps macrophages are differentiating into lymphatic endothelium. And based on what is known about the embryonic origins of lymphatic endothelium and lymphatic vessels, those models seemed unlikely to us. And potentially a more likely explanation is that the lymphatic vessels that form in bone actually originate from pre-existing lymphatic vessels located outside of the bone. So to test this hypothesis, we performed a lineage tracing experiment where using Cre recombinase, we were able to label pre-existing lymphatic vessels with green fluorescent protein and then express VEGF-C. And if our hypothesis were true, that lymphatic vessels in bone originate from pre-existing lymphatics, we would anticipate that the lymphatics in the bone would be GFP positive. On the other hand, if the lymphatic vessels that were in bone did not express GFP, then that would suggest that there is some other origin for these lymphatic vessels in bone, that they're not arising from the pre-existing lymphatics, but from some other cellular source. So we used a PROX1-driven tamoxifen-inducible Cre to label lymphatic endothelial cells with GFP. After a washout period, we then induced the expression of VEGF-C and found that the lymphatics in bone were actually GFP positive, suggesting that lymphatic vessels in bone arise from pre-existing lymphatic vessels. And an example of our staining is just shown here, where we looked at serial sections where you can see these podoplanin positive lymphatic vessels in the bone express GFP. We then went on to further characterize how these lymphatic vessels are actually getting into the bone from these pre-existing vessels located outside of bone. So to do that, we performed a time course study, and we focused our analysis on cross-sections of ribs. And we looked at lymphatic vessels in the periosseous muscle, the cortical bone, as well as the marrow cavity at mice at different stages of disease development. And what we found was that in control animals, as well as in mice with early stage disease, lymphatic vessels were restricted to this periosseous muscle, and that this thin layer of periosteum actually shielded the bone from the lymphatic vessels. We then found that our mice, our mutant animals, as their disease progressed, these abnormal lymphatic vessels in the periosseous muscle grew. They then breached the periosteum and came into contact with the bone. And then as time progressed, these vessels gradually passed through the cortical bone until later stages where we could then detect them in the marrow cavity. So these results suggest that bone lymphatics, or lymphatics in bone, develop by local invasion, where regional lymphatic vessels grow, breach the periosteum. We've also found that these vessels come into close contact with osteoclasts, and that they gradually invade the bone until they reach the marrow cavity. So our observation that lymphatic vessels that were in contact with the cortical bone were associated with osteoclasts led us to speculate that perhaps these osteoclasts were clearing a path through the bone for the lymphatic vessels. And I'll just show an example of what this actually looks like under the microscope, where here in serial sections that we've stained for lymphatics as well as osteoclasts, you can see this lymphatic vessel that's in the process of invading the cortical bone is closely associated with osteoclasts, and you can see these resorption pits, which appear to be creating a path through the bone for the lymphatic. So to determine whether osteoclasts were actually required or facilitate lymphatic vessel invasion of bone, we used a genetic approach to block osteoclast development in our mutant mice. So to do this, we bred in the OP mutation. This is a point mutation in the CSF1 gene. And mice that are homozygous for this mutation fail to develop osteoclasts. So through a series of breeding, we bred this into our model and collected bones from 32-day-old mice. And in mice which have osteoclasts, these are control animals, we were able to detect lymphatics in the periosseous muscle, the cortical bone, and in the marrow cavity. Whereas in these OP homozygous mutant animals, which lack osteoclasts, the lymphatic vessels grew outside of the bone. However, they didn't penetrate the cortical bone or reach the marrow cavity. So this has led us to our model where in normal settings, lymphatic vessels grow, breach the periosteum, and then gradually pass through the cortical bone with osteoclasts clearing a way for them. And in mice without osteoclasts, these lymphatic vessels grow, but fail to actually invade the cortical bone or the marrow cavity, suggesting that osteoclasts play an important role in facilitating lymphatic invasion of bone. So while we were doing these studies with our VEGF-C transgenic model, we formed a collaboration with a geneticist named Mika Vikula, and he was interested in identifying the genetic underpinnings of Gorham Stout disease. So actually identifying what mutations are responsible for causing this disease in patients. And he pursued the hypothesis that Gorham Stout disease is caused by a somatic genetic mutation. And he pursued that because, like Mike mentioned before, it's not an inherited disease, suggesting that it's not due to a germline mutation, but could potentially be due to a somatic genetic mutation. So to test this hypothesis, he sequenced affected and unaffected tissue from a patient that received a diagnosis of Gorham Stout disease after she presented with osteolytic lesions and intraosseous lymphatic malformations. And through his analysis, he identified an activating mutation in KRAS in the affected tissue in this patient. Just a reminder, KRAS is a small G protein which functions as a molecular switch. It is inactive when bound to GDP. When bound to GTP, it undergoes a conformational change which allows it to interact with downstream effector proteins and promote signal transduction. And the mutation that was present in the patient with Gorham Stout disease is a known mutation which impairs GTP hydrolysis, resulting in hyperactive downstream signaling. So to characterize the effect hyperactive KRAS signaling has on the development of lymphatic vessels, we have used a Cre-Lox system to express a related variant called the G12D variant from the endogenous KRAS locus. So in our animal model, after we administer tamoxifen to our mice, the Cre recombinase moves to the nucleus, and in our model, it induces the expression of GFP and mutant KRAS in lymphatic vessels. So we took our mice, fed them tamoxifen, and when they were 7 weeks old, we collected their bones and stained for lymphatic markers. And as anticipated, we did not see lymphatic vessels in control animals, whereas the bones from our mutant animals did contain lymphatic vessels. So we were able to see live one positive as well as podoplanin positive lymphatic vessels, suggesting that expression of mutant KRAS in lymphatic endothelium can lead to the formation of lymphatics in bone. While we were doing this experiment, we noticed that our KRAS mutant animals had reduced survival, and that the median survival of our mice was about 3 weeks. And we were able to analyze our mice and found that the mice that were in the process of dying or had recently died, their chest was actually filled with lymphatic fluid, this milky lymphatic fluid called chyle. And as Mike mentioned, this is a common problem in patients with Gorham Stout disease that have thoracic involvement. They develop chylothorax, which can be lethal. So chylothorax had previously been shown to be associated with defects in the formation of lymphatic valves. So as Mike mentioned, lymphatic vessels contain intraluminal valves which help direct the flow of lymph and prevent retrograde lymph flow. So to determine whether valves were abnormal in our KRAS mutant animals, we induced the expression of mutant KRAS in lymphatics, and then when mice were 3 weeks old, we analyzed their lymphatics in the skin. And in control animals, we could see valves, which were absent in our mutant animals, suggesting that hyperactive RAS signaling impairs the formation of lymphatic valves. So to investigate the molecular mechanisms by which hyperactive RAS signaling could affect the formation of lymphatic valves, we turned to an in vitro system where we treated primary human lymphatic endothelial cells with lentivirus particles to express either GFP or mutant KRAS. And we found that hyperactive RAS signaling caused these cells to change their morphology and switch from having a normal cobblestone morphology to this spindle morphology. Additionally, we found that expression of mutant KRAS induced signaling in our lymphatic endothelial cells. So two common pathways activated by mutant KRAS are the AKT and MAP kinase pathways. And we found by Western blot that the levels of phospho-AKT as well as phospho-ERK were increased in our mutant cells compared to our control cells. So to assess the impact of this on gene expression, we submitted samples for RNA sequencing and performed a differential gene expression analysis. And I just want to focus your attention to the heat maps, particularly this heat map, which is showing genes that have previously been shown to play an important role in the formation of lymphatic valves. And we found that many of these genes were downregulated in our KRAS mutant cells. We then became interested in assessing the effect of trametinib on the phenotype of our mutant cells. Trametinib is an FDA-approved MEK1 and MEK2 inhibitor and is an emerging therapy for complex lymphatic anomalies. So to determine whether trametinib impacted signaling in our lymphatic endothelial cells, we treated them with either vehicle or trametinib and found that trametinib could reduce the phosphorylation of ERK in our KRAS mutant cells. And we've also looked at gene expression and found that the expression of genes that promote the formation of lymphatic valves was increased by trametinib in our mutant cells. We then did a therapy study where we treated mutant animals with either vehicle or trametinib and found that trametinib increased the formation or presence of lymphatic valves in KRAS mutant animals compared to the vehicle-treated animals. So these results suggest that hyperactive RAS signaling in lymphatic endothelial cells leads to the formation of lymphatic vessels in bone. And unexpectedly, we found that it also impacts the formation of lymphatic valves, leading to the loss of lymphatic valves and retrograde lymph flow, and that we could restore valve development by treating mice with a FDA-approved MEK inhibitor. So because our KRAS mutant animals develop chylothorax and die before they have significant bone involvement, we weren't able to actually assess the effect of trametinib on the bone phenotype of our KRAS mutant animals. So this led us to actually turn back to our previously described VEGF-C transgenic model. And in this experiment, we induced the expression of VEGF-C like before during postnatal development and let mice develop disease. And when they were 21 days old, we treated them with either vehicle or trametinib. And we found that trametinib decreased the formation of lymphatic vessels in bone. We can see that here in femurs. We also see that in the cortical bone looking at ribs. So just to summarize my part of the presentation, we see that healthy individuals lack lymphatic vessels in bone, whereas GSD patients have lymphatics in bone. And GSD can be caused by somatic genetic mutations. An example is KRAS. However, recently in EML4 and ALK fusions were identified in 2 patients with Gorham Stout disease. We found that overexpression of VEGF-C in bone stimulates lymphatic invasion of bone, and that the expression of mutant KRAS in LECs also triggers lymphatic invasion of bone, and blocking MAP kinase signaling can attenuate disease progression in animal models of Gorham Stout disease. So to conclude, we have developed the first animal models of Gorham Stout disease. Our first generation is our VEGF-C transgenic model, which activates these pathways which are misregulated in patients. And our second generation model is based on the patient mutation, leading to the activation of the RAS-MAP kinase pathway. And these animal models are helping us develop a better understanding of the pathology of this disease. And we believe that our work will help with the repurposing of FDA-approved drugs for Gorham Stout disease. And like I said, enable a precision medicine approach for treating this life-threatening disease. And I just have 1 more or 2 more slides that I want to share with this group because I think that we can take what we are learning from Gorham Stout disease and actually apply it to other bone diseases. And the disease that we're looking at now is heterotopic ossification. And this is a condition where bone can form in non-skeletal tissues. We're focusing on a trauma-induced heterotopic ossification. And because lymphatic vessels can promote the destruction of bone in Gorham Stout disease, we hypothesize that lymphatic vessels might actually be able to promote the destruction of heterotopic bone in heterotopic ossification. So to test this hypothesis, we formed a collaboration with Benjamin Levy here at UT Southwestern, where he has an animal model of trauma-induced heterotopic ossification, where they cut the Achilles tendon and burn the animals, leading to the formation of heterotopic bone around the heel and in the Achilles tendon. And we've generated transgenic mice that were able to induce the growth of lymphatic vessels in this area. And lymphatic vessels, these are just bones from a control mouse, and lymphatic vessels are shown in red, and we do not see lymphatic vessels in the heterotopic bone. In our transgenic animals, the bones are filled with lymphatic vessels, and when we do micro CT, we find that our transgenic animals have less heterotopic bone than our controls. We're also inducing some of the destruction of the regional native bone, and we're working on modifying this. But I just wanted to share this because I think by studying Gorham Stout disease, we can not only improve the situation for those patients, but hopefully we can take what we've learned from this disease and apply it to other conditions. So with that, I would just like to thank you all for your attention and the members of my team and our funding sources and collaborators. Thank you.
Mike and Mike, what a great presentation. And I'm so excited because I have a number of these patients, and boy, do we need help. Before we go forward, we'll revert back to our usual standards. So I'm going to first redo our announcements for those who are late. We'll then take questions from the chat, and then Mike Kelly has a case for us, so I'm excited about that as well. So again, welcome everyone to our final presentation of year 6. Thank you, Mike and Mike. Next slide. For those of you on the call who are unaware, we're very sad to announce the passing of Dr. Francis Gloria. He certainly has impacted so many of our lives and made such an impact on improving the life of those with rare bone diseases. He will be sorely missed. As always, please help Michael. Please sign in at the link to say you were here, and please, at the end, complete the red cap survey so we can provide you with your free CME. Upcoming events. So this is the last of year 6. I cannot believe 6 years have gone by. We are not going to do July 3rd. It's too close to the holiday, but we'll be raring to go on August 7th. We haven't quite finished our schedule for next year, but I want to tickle your fancy with what we have coming up. We have commitments for all of the talks listed. So we'll hopefully have a final schedule for you very quickly. So please be sure to join us August 7th. Next slide. So also please remember that there is a specific OI teleecho series, and that's every other month. And so that will be June 11th, August 13th, and again in October, with very helpful talks, approach to genetic testing, cardiovascular disease, and certainly as an orthopod, a troublesome one for me, the clinical and genetic evaluation of non-accidental trauma versus OI. Next slide. ASBMR is coming up soon, and OI Foundation and Rare Bone Disease Alliance are really pushing to increase your access to more information on rare disease. We will once again be helping host a pre-meeting symposium rare bone disease, from the genome to the lived experience. We'll have a reception. Please sign up for early and mid-career investigators on Friday evening, just before the Pediatric Bone and Mineral Working Group dinner, which will focus on future therapies in children with calcium dyshomeostasis. So lots coming at ASBMR. Last but not least, we are trying to revive having a bone club in Washington, D.C., but a special one, metabolic and rare bone disease. The challenge always is we want to be more inclusive than ever. And so we will once again host this as a hybrid meeting, both in person and on Zoom. So if you would like to join us, please note on June 26th, Jenny Miller will speak to an introduction to ENPP1 and ABCC6 deficiencies. And please note the other dates.